Therapeutic hypothermia. This is a standard treatment for neonates with moderate to severe hypoxic ischemic encephalopathy. What are the criteria for neonatal therapeutic hypothermia? What are the benefits of therapeutic hypothermia? Hypoxic Ischemic Encephalopathy. Hypoxic Ischemic Encephalopathy HIE, it's a serious condition that occurs when an infant's brain does not receive enough oxygen and blood. This can happen before, during, or after birth. The lack of oxygen and blood can damage brain cells and lead, unfortunately, to neurological and developmental problems. Recognizing them and treating HIE as soon as possible is crucial to minimize its impact. One of the leading treatments for HIE is therapeutic hypothermia, also known as cooling therapy. What are causes and risk factors of HIE? The causes of HIE are varied and can include complications like umbilical cord problems, placental abruption, maternal hypotension, or a difficult delivery. Perinatal asphyxia, in case of prolonged labor, may be caused by something that is called dystocia, difficult labor that lasts for extended period and can reduce oxygen delivery to the baby. Then failure to progress during the delivery. When labor does not progress as expected, the baby may experience reduced oxygen levels to all organs and brain. Placental issues, placental abruption, so premature separation of the placenta from the uterine wall disrupts the supply of oxygen and nutrients to the baby. Placenta previa. The placenta covers the cervix. This is in the case when the placenta covers the cervix, potentially leading to bleeding and reduced oxygen supply during labor. And umbilical cord complications. Cord prolapse. The umbilical cord slips into the birth canal ahead of the baby, compressing and restricting blood flow to the baby. Very common thing, nuchal cord, when the umbilical cord wraps around baby's neck, potentially limiting blood and oxygen flow. Cord compression, so pressure on the cord due to the baby's position or other factors that can reduce oxygen delivery. Then very serious condition, uterine rupture. A tear in the uterine wall can lead to hemorrhage and compromise the oxygen supply to the fetus. Also, maternal health issues increase risk of HIE, such as preeclampsia and eclampsia, so high blood pressure and damage to organs like liver, kidneys can reduce blood flow to the placenta, decreasing oxygen supply to the fetus. Maternal diabetes plays a role. So uncontrolled diabetes can lead to large for gestational age LGA babies, increasing the risk of birth complications and asphyxia. Maternal infections such as chorioamnionitis increase risk of HIE. Infections of the fetal membranes that can cause inflammation and again compromise oxygen delivery to the baby. Maternal substance abuse, so use of drugs, alcohol, tobacco, can negatively impact fetal oxygenation and development. What about neonatal complications? Premature birth. So premature babies have underdeveloped organs, including the lungs, making them more susceptible to oxygen deprivation and respiratory distress, putting them at increased risk of HIE. Post-maturity, very important factor. Babies born significantly past their due date may experience reduced placental function, leading to insufficient oxygen supply during the delivery and increase significantly risk of HIE. Low birth weight. Babies with low birth weight may have compromised health and less reserve to tolerate the stress of labor and delivery. Also, multiple births put babies at increased risk of HIE, so twins, triplets, or other multiples are at increased risk of complications during delivery, including cord entanglement and reduced oxygenation. Some delivery-related factors that put babies at increased risk for HIE: breech presentation, so babies position feet or buttocks first, may experience more challenging deliveries and potential oxygen deprivation. As mentioned already, shoulder dystocia, so difficulty delivering the baby's shoulder after the head has emerged, can lead to compressed umbilical cord and reduced oxygen flow. Meconium aspiration. If the baby inhales meconium-state amniotic fluid, it can block airways and cause severe respiratory distress. And other factors that can increase risk of HIE: fetal distress, so signs of fetal distress during labor such as abnormal heart rate patterns indicate potential oxygen deprivation. Anemia in the fetus, so condition like Rh incompatibility can lead to severe anemia of the fetus, reducing oxygen carrying capacity of the blood. What about symptoms of hypoxic ischemic encephalopathy? Symptoms can vary widely depending on the severity of oxygen deprivation and the extent of the brain injury. They can lead to be categorized based on the level of severity to mild, moderate, and severe. So first, mild HIE. Those babies present with some increased irritability. Those babies may be unusually fussy, or they are difficult to soothe. They may be very alerted and irritable. The newborn may appear more awake or alert than usual. Those babies may be jittery. They may have tremors, shaking, which are not seizures but may indicate central nervous system stress and irritation. Those babies with mild HIE, they have normal or slightly decreased muscle tone. The baby may have slightly decreased muscle strength, but generally can move all four extremities normally. Babies with mild HIE, they struggle with feeding. They may have difficulty in sucking and swallowing, leading to poor feeding. All those symptoms, though, usually resolve within 24 to 48 hours. Let's move to moderate HIE. Those babies have more pronounced symptoms. They are lethargic, they may be drowsy, they may be less responsive to stimuli. They are hypotonic, so they have decreased muscle tone, leading to a flappy appearance. They have decreased reflexes, weak or absent reflexes such as motor reflex, which is a startle reflex. Some babies experience seizures. Those seizures may begin within first 24 hours after birth, and they can be either subtle, including some eye rolling, lip smacking, on some jerking movements. Again, they present with poor feeding, which is more pronounced than in case of mild HIE. Sometimes they don't have suck reflex, they have difficulty swallowing. Often those babies have problems with breathing, so they have periods of apnea, which is a pause in breathing, or they have irregular breathing patterns. They may have abnormal movements, so repetitive involuntary movements such as twitching or jitteriness, which can be seizures. And symptoms in moderate HIE persist for longer, several days or even weeks. In case of severe HIE, Those babies are often unresponsive to stimuli. They may appear to be in a deep sleep. They have severe hypotonia, so very weak muscle tone with little or no spontaneous movement, not even response to painful stimuli. Absent reflexes such as sucking, grasping, and motor reflexes, so those reflexes are completely gone. Seizures are frequent in those cases, and often those babies have severe seizures. Those seizures are more difficult to control and may be more evident with severe jerking or twitching. Those babies often present also with severe respiratory problems requiring mechanical ventilation, and they have multi-organ dysfunction, very often signs of damage to other organs such as poor kidney function, liver dysfunction, cardiovascular instability. Abnormal posturing, it may be also a sign of severe HIE, so the cerebrate or the corticate posturing that indicates severe brain injury. And finally, feeding intolerance, inability to feed by mouth, often requiring tube feeding or intravenous nutrition. How do we diagnose HIE? Diagnosis HIE involves a combination of clinical assessment, imaging studies, and laboratory tests to determine the extent of brain injury and then the underlying cause. The diagnostic process typically includes the following steps. Number 1, clinical assessment. APGAR score, so scoring at 1 and 5 and 10 minutes after birth. APGAR scores measures heart rate, respiratory effort, muscle tone, reflex response, and baby's color. Low scores, especially if prolonged beyond 10 minutes, can indicate possible HIE. Then next step, neurological examination. So assessment of muscle tone. Is hypotonia present, which is reduced again muscle tone, or hypertonia, increased muscle tone? Both can indicate brain injury. Checking reflexes, so abnormal reflexes such as weak suck, weak moro reflex suggest neurological dysfunction. Level of consciousness, so observing signs of either lethargy, irritability, stupor, or even coma. Presence of seizures in the newborn is a significant indicator of HIV. In regards to imaging studies, magnetic resonance imaging, MRI, identifies early brain injury by detecting changes in water movement in brain tissue. Conventional MRI assesses the extent of location of brain injury, including wide and grey matter involvement. Then some study that we do perform early during the first 24 hours after baby is admitted to neonatal ICU, cranial ultrasound. This is again initial assessment. It's used in the first 24 hours of life to detect possible brain hemorrhage or large areas of brain injury. CT scan, it's used less frequently in neonates due to radiation exposure, but it may be employed in emergency situation to quickly assess brain injury on bleeding. And now, very important imaging, EEG, electroencephalography, continuous EEG monitoring. That's what we use, especially within first 48 hours of baby's life. Detects seizures, so identifies subclinical seizures that often may not be apparent on clinical examination. So we may not see it, but on continuous EEG we do see seizure activity. EEG evaluates brain activity, so assesses the severity of encephalopathy and helps predict long-term outcomes. Then other type of EEG, amplitude integrated AEEG. It's used for continuous bedside monitoring, providing a graphical display of brain activity patterns. In regards to laboratory tests, blood gas analysis, so we do check on admission to neonatal ICU. At birth, we measure blood gases and acid-base status to assess the degree of hypoxia experienced during labor and delivery. Arterial blood gases also measures oxygen, carbon dioxide levels and blood pH to assess respiratory and metabolic status of the baby. Often what we do see, it's something that it's called metabolic acidosis, which is a low pH, elevated lactate levels. Those can indicate significant hypoxia. Another blood test, CBC, can identify either anemia or eventually infections. Electrolytes monitors for imbalances that may affect brain function, glucose levels. Those babies are often hypoglycemic. Hypoglycemia can worsen brain injury, so we do monitor that quite often. We do also check coagulation profile. So coagulation profile assesses bleeding and clotting. It's important to check that if there is any signs of hemorrhage or something that is called DIC during the hypothermia process. And metabolic screening identifies eventual inborn error of metabolism, condition that may mimic or contribute to HIE. So while the baby is in the NICU, we monitor those blood tests quite often. Sometimes it's every 12 hours, sometimes even more often, to make sure that we are providing enough respiratory support, oxygenation to control and eventually treat bleeding problems, to treat infection or to treat anemia. In regards to now treatment of hypoxic ischemic encephalopathy, we can divide it to immediate interventions such as resuscitation, so neonatal resuscitation, immediate measures to ensure adequate breathing, circulation, including in the delivery room, sectioning of the airway, providing oxygen, initiating positive pressure ventilation if that's necessary. In cases of severe distress, those babies sometimes require intubation and mechanical ventilation. Therapeutic hypothermia. This is a standard treatment for neonates with moderate to severe hypoxic ischemic encephalopathy. This intervention aims to reduce brain injury by lowering the infant's body temperature, thereby slowing metabolic process and limiting the cascade of injury mechanisms that follow an initial hypoxic ischemic event. This is very important because we want brain to kind of rest during that time of hypothermia therapy. And now, what kind of hypothermia therapy do we have? Most often used whole body cooling when the infant's body temperature is lowered to around 33.5 degrees of Celsius for 72 hours, even to reduce metabolic demand and again minimize brain injury. It must be initiated, though, that's very important, within 6 hours after birth in order to be effective. What are the criteria for neonatal therapeutic hypothermia? Gestational age. So babies greater or equal to 36 weeks of gestation qualify. Then those babies must have signs of moderate to severe encephalopathy, such as, for example, altered consciousness, hypotonia, seizures, or abnormal reflexes. Then evidence of perinatal asphyxia, so low Apgar score, less than 5 at 10 minutes of life, need for resuscitation at birth, or presence of metabolic acidosis when pH is less than 7 or base deficit more or equal to 16 within the first hour of life. Those are criteria for qualification of entering hypothermia therapy. What is the mechanism of action? Again, hypothermia treatment. Reduction of metabolic rate, as already mentioned. Hypothermia decreases the brain's metabolic demands, reducing the need for oxygen and glucose. Then inhibition of excitotoxicity. So cooling inhibits the excessive release of excitatory neurotransmitters like glutamate, which can lead to neuronal injury after the initial event. Then reduction of inflammation. Hypothermia limits the inflammatory response that can exacerbate brain injury. Something that is called apoptosis, prevention of apoptosis. So cooling helps prevent programmed cells death, which is called apoptosis, that occurs in neurons after hypoxic ischemic injury. Hypothermia therapy, I mentioned that cooling is continued for 72 hours. After that time, we go to rewarming. We rewarm the baby. There's a rewarming phase. When we rewarm the baby, it's a gradual process as well. So rewarming lasts over 6 to 12 hours to avoid rapid temperature fluctuations that could lead to complications. What do we monitor? What do we need to monitor in those babies with HIE that are undergoing therapeutic hypothermia therapy? Vital signs, so continuous monitoring of heart rate, respiratory rate, blood pressure, oxygen saturations are important. Very often, again, those babies need mechanical ventilation, they need oxygen, they often have low blood pressure, they need medication to increase their blood pressure. Then temperature monitoring. So core temperature, we mentioned that it needs to be maintained at 33.5 degrees of Celsius. So core temperature is closely monitored using either rectal or esophageal probes. Neurological monitoring, regular neurological assessments by pediatric neurologists and continuous EEG monitoring. It's important to detect any seizures that we may not even see clinically, but they are present, and then manage those seizures with medications. Laboratory tests, so frequent blood tests to monitor electrolytes, check for acidosis, blood glucose level, liver and kidney function, because blood supply and oxygen levels were deprived to all organs, not just brain. Liver and kidneys are also often affected, and then coagulation status and eventually correcting coagulation problems in those babies. What are the benefits of therapeutic hypothermia? Neuroprotection, that's the first one. So significant reduction in extent of brain injury. That's what we achieve by hypothermia treatment. It leads to improved neurological outcomes. Reduced mortality. It's been proven that babies that undergo therapeutic hypothermia, they have lower risk of death. Those babies that have moderate to severe HIE who receive timely therapeutic hypothermia, they have improved mortality. It's been also shown that therapeutic hypothermia improves long-term neurodevelopmental outcomes. So better developmental outcomes, including motor skills, cognitive function, and behavior. What are the risks and complications of therapeutic hypothermia? Because there's always risk complications of any treatment. Bradycardia, so lower heart rate due to reduced metabolic rate, and very low temperature. Generally, bradycardia is very well tolerated in absence of other complications. Then mention coagulopathy with hypothermia, so increased risk of bleeding due to impaired clotting function, requires careful monitoring and eventual treatment. Hypothermia can cause electrolyte imbalance, so changes in electrolyte levels that necessitate close monitoring and adjustment with IV fluids. Therapeutic hypothermia can cause increased risk of infection, so those babies are more susceptible to infection due to impaired response. Skin injuries, sometimes it does happen that those babies have skin breakdowns or frostbites if cooling equipment is not properly managed. Babies that are admitted for hypothermia therapy, beside hypothermia therapy, they also need some supportive care. Respiratory support, sometimes they are breathing while in room air, sometimes they need little bit of oxygen, little bit of support oxygen, positive pressure ventilation, or even mechanical ventilation. Nutritional support, we are not feeding babies that undergo therapeutic hypothermia for those 72 hours while they are being cold. We are providing them calories through something that's called total parenteral nutrition, which some sugar, some protein, some lipids, vitamins, microelements in order to provide those babies nutrition and calories. Fluid and electrolyte management, so not only to maintain hydration for those babies, but to correct eventual electrolyte imbalance. Seizure management. I mentioned that sometimes those babies need seizure medications such as phenobarbital or phenytoin or levetiracetam to control seizures. Continuous EEG monitoring, again very important to detect those seizures that are not visible on clinical assessment. What is the prognosis for infants with HIE? Again, it depends on the severity of initial injury, then timelines and effectiveness of intervention, and presence of underlying conditions. Early therapeutic hypothermia has been shown to improve outcomes for many infants. In regards to prognosis, of course, prognosis will depend if we are dealing with mild, moderate, or severe encephalopathy. So babies with mild HIE, generally this is associated with good prognosis. Most infants with mild HIE will have normal development or only minor deficits. Moderate HIE prognosis is here more variable. With therapeutic hypothermia, many infants have favorable outcomes, but there is still a risk of developmental delays and neurological impairments later in those babies' life. And severe HIE prognosis here is very guarded. Despite therapeutic hypothermia, these infants have higher risk of significant and severe long-term neurological disabilities and mortality. In regards to timing of intervention, I already mentioned that therapeutic hypothermia treatment, it needs to be initiated within the first 6 hours after birth. Delayed initiation reduces the effectiveness of neuroprotection of therapeutic hypothermia treatment. Then response to therapeutic hypothermia matters as well. Infants who respond well to cooling therapy typically have better outcomes than those that do not. Presence of seizures is important in regards to prognosis, long-term prognosis. So early and frequent seizures are associated with worse prognosis. Effective seizure management can improve outcomes. And after the baby is warmed up, on day of life 5 to 7, we usually do MRI of the brain, and this MRI of the brain can also provide us very important prognostic information. Patterns of injury on MRI, for example, such as basal ganglia or thalamus injury, are associated with poorer outcomes, but here we need expertise and experience of pediatric neurologists in regards to help us with MRI readings and prognosis. EEG patterns, abnormal EEG findings such as burst suppression or persistent low voltage activity are linked also to with worse neurological outcomes. Long-term symptoms and complications of HIE may include a range of developmental, cognitive, and motor challenges. Many children can achieve significant improvements, though, in function and quality of life. Motor deficits, those babies are at increased risk of cerebral palsy, which is a group of disorders affecting movement and muscle tone. Spasticity, I cannot pronounce today, increased muscle tone leading to stiffness and difficulty with movement. Those babies have sometimes that it's called ataxia, so problems with coordination and balance. Those babies are also at increased risk of cognitive impairments, developmental delays, delayed achievement of milestones such as sitting, walking, talking. Then learning disabilities, difficulties with learning, memory, problem solving, behavioral issues, attention deficit hyperactivity disorder, problems with attention, hyperactivity, impulsivity. Those babies often have difficulties controlling emotions and behavior. They may have delayed speech, slower development of speech and language skills, difficulty in articulating words due to muscle control issues. They may have sensory impairments, partial or complete hearing loss, issues such as cortical visual impairment, where the brain has difficulty processing visual information. Seizure disorders, sometimes they need to stay on seizure medication for a prolonged period of time. We discharge them on seizure medication, and then they follow up with pediatric neurologists as outpatient. What is important after discharge from neonatal ICU? Regular developmental assessments, so early and ongoing evaluation to monitor growth, developmental milestones, neurological function, early intervention services. Very important, improve outcomes, physical therapy to improve motor skills and muscle strength, occupational therapy to support fine motor skills, daily living activities and sensory integration, speech therapy to address speech and language delays, and then educational support. So individualized education plans, tailored education plans to support children with developmental and learning challenges, and additional resources to support within the school system. It's important to also educate and support families of babies that have hypoxic ischemic encephalopathy, so providing families with information and resources to understand and manage the condition, connecting those families with support groups and counseling services to address emotional and psychological needs. In conclusion, the prognosis for neonates with HIE is influenced by the severity of injury, the timelines and effectiveness of treatment, and various individual factors. Early intervention with therapeutic hypothermia has significantly improved outcomes for many babies. Long-term follow-up and comprehensive support are essential to optimize the developmental potential and quality of life for children affected by hypoxic ischemic encephalopathy. Any questions, any concerns, please contact me at neonatologyforparents.com. Thank you.